Hello, everyone. Thank you to SAGES and to our moderators for the opportunity of presenting our study here today. So this is our disclose. It is well known that minimally invasive procedures have increased over the past few decades. Still, several studies have shown the difference between minimally invasive procedures and how they are better, and they have better outcomes when compared to its open counterpart, with lower complications and readmission rates, shorter length of stay, and with less cost. However, little data is available for comparisons between robotic and laparoscopic procedures. This is why we evaluated and compared outcomes, cost effectiveness, and intra-hospital opiate utilization between patients who underwent open laparoscopic and ventral hernia repairs. For that, we looked at the VISIAN database from January 2013 to October 2015 using ICD-9 procedures and diagnosis codes for open laparoscopic and robotic ventral hernia repairs. This is a list of the outcomes that were measured, and we used chi-square parametrics and non-parametric tests for statistical analysis. So, as a result, we had almost 47,000 patients who were included in this study, and open procedure was the highest, have the higher utilization rate. Still, only 1% of the patients underwent robotic ventral hernia repair. This table shows the demographics of our patients. So as you can see, both groups had similar mean age, and they were predominantly comprised by female patients. This table shows our outcomes results for each procedure, for each approach. And as you can see, our data revealed that open ventral hernia repair had worse overall outcomes when compared to both laparoscopic and robotic groups, with the highest rate of overall complications, 30-day readmissions, and with the longest length of stay. When we looked at minimally invasive approaches only, we saw that both laparoscopic and robotic group did not seem to differ in mortality, 30-day readmissions, and in length of stay, although robot was found to have a higher overall complication and postoperative infection rate compared to the laparoscopic group. Our cost analysis revealed that robotic was the most expensive group, followed by open approach and laparoscopy, which was the least expensive. So VISIAN uses resource units as a methodology to account for opioid utilization in the database. So each drug has its unique variable of unit. So our opioid utilization results showed that there was no difference in overall absolute number of patients who were prescribed opiates during the intra-hospitalization. However, patients who underwent open ventral hernia repairs received more units. They had a longer duration of utilization and therefore a higher cost. But patients who underwent laparoscopic and robotic ventral hernia repair did seem to receive similar units, and they had similar duration of utilization and similar costs. We are aware of the limitations of using an administrative database. We did not have hernia characteristics or long-term follow-up for our patients, and we could not compare surgical techniques, specifically including the use of tags or transfascial fixation in either group. In conclusion, our data revealed that minimally invasive approaches had better overall outcomes than the open ventral hernia repair, and both laparoscopic and robotic ventral hernia repairs had similar short-term outcomes and similar opiates utilization. Due to a small number of robotic cases, a slight increase was seen in overall complications and postoperative infections in robotic group when compared to laparoscopy. And cost analysis revealed a wide variation in cost, with laparoscopy approach being the least expensive of all. Thank you.
Do we have any questions? If not, I appreciate your talk. One question, and it's always difficult with these types of databases, but how, briefly, was cost generally determined in these cohorts?
Well, thank you for your question. Yes, we looked at direct cost specifically. We did not look at the breakdown for each cost. I don't know if it answers your question.
There's a question at the microphone.
To follow about cost, what component of the cost structure was so significant that it increased the cost of the open procedure? Why the open procedure was so expensive?
Well, we were expecting the open procedures to be more expensive because it takes into consideration how many days the patients were there, and they had a longer length of stay. Although the comparisons between robotic and open actually was a surprise for us, but still we have just a small number of patients in the robotic group, so we cannot say if it was significant.
So length of stay was the major component, correct?
We did not calculate the breakdown for the cost, but we assume that that is why the cost was expensive for open.
I have a question. Does this database capture post-discharge complications as efficiently as inpatient?
Yes, so the database captures 30 days readmission and 30 days outcomes, so they capture it as equally, yes. Okay. But we have no long-term follow-up.
Thank you. Thank you very much.